In 1847, the American Medical Association was founded. At the time, it had fewer than 200 members. At that exact same moment, there were already over 150 hospitals operating across the United States. And by the time the AMA had enough doctors to credibly call itself a professional body, that number had climbed past 400. So here's the question history keeps skipping over. Who built them? Not who staffed them, not who invented the treatments used inside them, but who actually raised the money, laid the bricks, organized the labor, and decided that a city, a county, a neighborhood, a coal patch needed a place where sick people could go. Because the answer isn't what you've been taught. The answer has been quietly buried under a century of professional mythology, political convenience, and one infamous report written by a man who had never once practiced medicine in his life. This is the story of who actually built American healthcare, and why the people who did it never got credit for it. Let's start with a number that doesn't make sense on its surface. In 1800, there were exactly 2 hospitals in the United States that resembled what we would recognize as hospitals today. Pennsylvania Hospital in Philadelphia, founded in 1751, and New York Hospital, founded in 1791. That's it. 2 institutions for a country of 5 million people. By 1873, there were 178 hospitals. By 1890, over 600. By 1910, more than 4,000. That's a 2,000% increase in less than 4 decades. And formal medical education barely moved during the same period. In 1900, there were roughly 160 medical schools in the United States, many of them diploma mills, most of them graduating students after just 2 years of largely theoretical study. There was no licensing standard. There was no board certification. A man could complete a 6-month correspondence course, receive a printed certificate, and legally practice medicine in most states. So when 4,000 hospitals appeared across the American landscape between 1870 and 1910, they weren't built because there were suddenly enough doctors to fill them. They were built because 4 entirely different groups of people decided to build them. And those groups had almost nothing to do with organized medicine. The first group was the one hiding in the most plain sight: religious sisters. Between the Civil War and the First World War, Catholic religious orders built more hospitals in the United States than any other institution, public or private. The Sisters of Mercy alone operated 41 hospitals by 1910. The Sisters of Charity ran facilities across New York, Maryland, Ohio, and into the Deep South. The Alexian brothers were building hospitals in Chicago and St. Louis before either city had a functioning board of health. These women weren't doing charity work in any condescending sense of the term. They were running sophisticated operations. They organized funding drives, they negotiated with city governments, they trained their own nursing staffs, they built supply chains for pharmaceuticals that barely existed as an industry. When a mining accident killed 30 men in a single afternoon, it was frequently a religious order that had the only facility capable of handling mass casualties. The scale of what they built is difficult to overstate. Historian Christopher Kaufman estimated that by 1915, Catholic institutions accounted for nearly 1 in 5 hospital beds in the United States. In some Western states, it was closer to 1 in 2. But here's where the story gets complicated. They built all of this without being recognized as medical professionals, without being allowed into the AMA, without a single seat at the table when decisions were made about the future of American healthcare. The women who built the infrastructure were told, politely and then not so politely, that the infrastructure now belonged to someone else. The second group is even less visible in the history books. African American communities, particularly in the South, built their own parallel hospital systems starting in the 1870s, not because they wanted parallel systems, because they had no choice. The Reconstruction era brought a brief window when black physicians trained at institutions like Howard University and Meharry Medical College. By the 1890s, there were roughly 900 black physicians practicing in the United States, and virtually every white hospital in the country refused to grant them admitting privileges, which meant that their patients, who were also black, had nowhere to go when they needed surgery, childbirth assistance, or treatment for anything more serious than a cold. So black communities built their own. Freedmen's Hospital in Washington was established in 1862, originally to serve formerly enslaved people who had fled to the capital. By 1900, there were at least 40 black-owned and black-operated hospitals across the South and Midwest. Provident Hospital in Chicago, founded in 1891 by Daniel Hale Williams, who would become the first surgeon to successfully perform open-heart surgery, was built entirely through community fundraising from Chicago's black population. These hospitals trained black nurses and doctors. They served communities that had no other option. They operated on shoestring budgets, fought for every piece of equipment, and maintained standards that rivaled their white counterparts by almost any measurable outcome. And then, in 1910, a report was published that would wipe out most of them within a decade. Abraham Flexner was an educator from Louisville, Kentucky. He had a bachelor's degree from Johns Hopkins and a genuine talent for institutional analysis. He had never attended medical school. He had never treated a patient. He had no background in public health, hospital administration, or anything remotely adjacent to clinical medicine. In 1908, the Carnegie Foundation hired him to survey American medical education. He spent 18 months visiting 155 medical schools across the United States and Canada. In 1910, he published his findings in a document known as the Flexner Report. The report argued that American medical education was a disaster, which was largely accurate. The diploma mills were real. The 2-year programs were genuinely inadequate. The lack of standardization was producing undertrained practitioners. On these points, Flexner was right, but embedded in his solutions were assumptions that had nothing to do with medicine. Flexner recommended that the number of medical schools be drastically reduced, from 155 to 31. He recommended that all surviving schools adopt the Johns Hopkins model, which required a 4-year university degree before admission, 2 years of laboratory science, and 2 years of clinical training. He recommended strict licensing requirements and national board examinations. On the surface, this sounded like progress. In practice, it was a mechanism of exclusion. The Hopkins model was expensive, prohibitively expensive. It required students to spend 6 to 8 years in full-time education before earning $1. It required schools to maintain laboratory facilities that cost hundreds of thousands of dollars to build and staff. It required a university affiliation that most independent institutions couldn't afford to acquire. The schools that survived were the ones with access to major philanthropic capital. The Rockefeller Foundation and the Carnegie Foundation funded the transition. They funded it selectively. The 5 black medical schools operating in 1910 were reduced to 2. Howard and Meharry survived. The rest closed. And without black medical schools producing black physicians, the black hospitals that depended on those physicians began to close as well. By 1930, the number of black physicians in the United States had dropped by nearly 50% from its 1900 peak. Not because black Americans stopped wanting to practice medicine, because the institutional infrastructure that trained them had been deliberately defunded and eliminated. The third group that built American hospitals was one that economists have almost entirely ignored: fraternal organizations and mutual aid societies. In the late 19th century, fraternal lodges were one of the primary social safety nets available to working Americans. The Elks, the Masons, the Oddfellows, the Ancient Order of Hibernians, dozens of ethnic mutual aid societies serving German, Italian, Polish, Greek, and Jewish immigrant communities. These organizations collected dues from their members and used the pooled money to pay for medical care, funeral expenses, and disability support. As their membership grew and their reserves deepened, many of them built physical facilities. The Shriners Hospitals for Children, which still operate today, were founded in 1922 and within a decade had opened 12 facilities across North America. The Jewish hospital network, which grew from small dispensaries serving Lower East Side immigrants in the 1880s, became a sprawling system of institutions, including what are now major academic medical centers. These weren't charity hospitals in the Victorian sense, built by wealthy philanthropists as acts of noblesse oblige toward the deserving poor. They were member-owned institutions built through democratic processes, governed by people who used them and funded by the people they served. They were, functionally, a form of collective healthcare that the United States had and then systematically dismantled. The Flexner Report didn't target them directly, but the licensing requirements it created effectively broke the lodge practice model. When states began requiring that physicians be licensed, and when the AMA used licensing boards to restrict the supply of physicians, The doctors who had previously contracted with fraternal lodges to provide care for a fixed annual fee found they had other options that paid better. The lodge practice system collapsed within 2 decades. The fourth group was the one with the most straightforward motive: industrial corporations. Mining companies, railroad companies, and timber operations in the late 19th century faced a practical problem. Their workers operated in remote locations, far from any existing medical infrastructure. When a man lost a hand in a mining accident or developed pneumonia in a logging camp, there was nowhere to take him, which meant he died, or he recovered slowly and incompletely, and either way the company lost productivity. The solution was company hospitals. Mining operations in Pennsylvania, West Virginia, Colorado, and the territories built their own medical facilities. The railroad companies, operating across thousands of miles of territory, with no municipal infrastructure at all, built hospitals along their routes. The Southern Pacific Railroad operated an extensive hospital system from San Francisco to New Orleans. The company deducted $1 a month from worker wages, whether workers wanted the deduction or not, and used the pooled funds to staff and maintain the facilities. This is, it's worth noting, the basic structure of employer-sponsored health insurance, the deduction model that would later evolve into the benefit system that currently covers 160 million Americans. Was invented not by insurance companies or labor unions or government programs. It was invented by railroad companies who needed their workers functional and who had enough political power to make the deduction involuntary. So by 1910, you had an American hospital system built by nuns, by black communities, by fraternal lodges, by immigrant mutual aid societies, and by industrial corporations. You had over 4,000 hospitals. You had millions of Americans with access to institutional medical care that hadn't existed 40 years earlier. And then organized medicine decided it was time to take over. The Flexner Report was the mechanism. The AMA's control of state licensing boards was the enforcement tool. And the Rockefeller and Carnegie foundations provided the capital that made the transition irreversible. Within 20 years of the report's publication, the hospital system had been professionalized in a very specific way. Professionalized to serve the priorities of a narrow class of university-trained physicians, predominantly male, predominantly white, predominantly from families with enough wealth to fund 8 years of preclinical education. The women who had built hundreds of hospitals were not in the room when the new rules were written. The black physicians whose communities had bootstrapped parallel institutions from nothing were not in the room. The immigrant workers whose dues had funded dispensaries and clinics were certainly not in the room. What got built instead was a system optimized for the people who built it in the second phase. The people who took what others had created and wrote the rules that governed who could participate in it. There's a version of American healthcare history that gets told in medical schools and policy discussions that goes roughly like this. Before the 20th century, medicine was unscientific and dangerous. The Flexner Report introduced scientific rigor and standards. Modern medicine emerged from that rigor, and the American healthcare system, for all its flaws, is the product of that scientific tradition. There's enough truth in that story to make it convincing. There were genuine charlatans. There were genuine problems with pre-Flexner medical education. Scientific medicine did produce outcomes that lodge practice and religious nursing couldn't replicate. But the story leaves out who paid the price for the transition. It leaves out the black physician population that was cut nearly in half. It leaves out the mutual aid systems that were broken by regulatory capture. It leaves out the Catholic nursing sisters who built more hospitals than anyone and were written out of the history of the institutions they created. And it leaves out a question that has enormous relevance right now. If communities built functional healthcare infrastructure through collective action, once, without significant government support, without the AMA, without insurance companies, without any of the institutions we currently treat as indispensable, what does that tell us about what's actually possible? The 4,000 hospitals weren't built because the conditions were perfect. They were built because people who needed them organized to build them, pooled their resources, trained their own labor, and solved a problem that no one with power was interested in solving for them. They built them in mining camps and immigrant tenements and freedmen's settlements and rural counties where the nearest doctor was 2 days by horse. They built them without venture capital, without government grants, without a single editorial in a major newspaper celebrating their ingenuity. They built them because waiting for permission from people who didn't care whether they lived or died was not a strategy. That's not just history. That's a model. And understanding why it was dismantled might be the most important question in American healthcare policy that nobody is currently asking.